Hello everyone, my name's Ben Gowland. I'm the director at Ockham Healthcare, and I'm going to talk today about what to do if your GP practice is falling into crisis. What are the things that you can do to tackle that as a practice? I think the starting point, the thing that's really important to understand, is what actually will make a crisis happen in a practice. And everyone will know the different challenges that general practice is facing at present. I mean, they particularly manifest in terms of workload. Most GPs would now say that their workload is impacting on their personal life as well as the quality of care that they're able to give to patients. And at the same time, in many practices, drawings are down, and in some places, drawings down to a level where they're only on a par or just above that which salaried and locum GPs are earning. But generally, the crisis itself comes when one or maybe two partners leave or retire, particularly when that happens unexpectedly. And so you have this smaller group of partners who feel trapped. They're worried about this prospect of being the last man standing, that they'll be on their own with all the risk of closure being left with them, and they're concerned that more partners are not going to be able to be recruited into the practice, and that's often the point at which the crisis occurs. Also, more common at the moment is if the same thing has happened to another practice in the town, where they've actually got to the place whereby they're either about to or have given in notice. And then you've got this concern about what's the commissioner going to do with that practice. Is there going to be a list dispersal? Is there going to be an entrant of a private sector provider? Is there going to be potentially a forced merger? And so those two things are the things that actually cause a crisis to occur. So what do you do? What do you do when your practice is at that point and is thinking we just cannot carry on with the way things are going? Now, I think there are four options that practices open to practices at this point. So the practice can look at how it works as a practice, and is there ways it can change that. It can introduce new roles. It can look at operating at scale, and it can create partnerships with other organisations and explore this whole new models of care. And what I'm going to do in this presentation is talk through those four and understand at what point and in what circumstances you might employ either of those. I think what I would say as a starting point is, though, that there isn't a single right answer. And so it's important not to think, okay, we're definitely going to merge, or we're definitely going to form a new model of care. The important starting point is being really clear of the options available, what's going to work best for you. We, as a company, go into practices quite commonly, and we'll look with the practice to see whether it's possible to make the current model that they have make that work. And we'll look at a whole range of things, and you can see the things listed on the slide there. Have they got enough GPs? How are they using locums? Can that look? Because often it's the locum usage that will drive financial problems in a practice. Is it a different system? Does every GP use their own system, or is there a common system for the practice as a whole? Is the practice manager effective? Does the practice even know whether their own practice manager is effective? And there are some really helpful things in the 10 high impact actions, and in the slides there are links to those things. Things like workflow redirection, whereby the post that comes into a practice is dealt with by the admin staff, and that a lot of that work is taken away from a GP, and that can free up, between 30 and 60 minutes a day for GPs. And also active signposting, whereby receptionists can be trained to, when the patients call in, to direct some patients away from having to see a GP. And in places where that's done well, they've been able to remove up to 25% of the workload away from GPs. So there are things that practices can do to improve their existing model. But the important starting point about whether you'd even go down there as a potential solution is being clear whether the partners want to make the model that they've currently got work. So if the problem in the practice is that the partners feel trapped, that there used to be 6 partners and now there's 3 partners, and they feel trapped and they're concerned that if someone else leaves, they'll be just left holding the baby. The issue isn't get the practice more efficient and make it work. A different type of solution is going to be used. So a really, really important starting point is being really clear as a practice what the problems are trying to solve. And it might not be the same for every partner. So it's important to have that discussion and try and work out across all the partners, what is the thing that concerns you most? Have we got a collective set of things that we know we're trying to solve? And then start to map the solution, the potential solutions that you're discussing against those problems to make sure that what you do is actually going to tackle the issues that you've got. So if making the practice more efficient isn't the thing that you can do, then I mean it's kind of linked, but I think it is different. Is this the introducing new roles into the practice? And I don't just mean introducing one. I'm saying radically change the way the clinical workforce is structured. Because if the real problem is you can't get GPs into the practice, you're reliant on locums, you've tried GP recruitment over and over and it's just failed, then for some practices the thing to do is go, okay, what we need to do is look at these other roles and work out, can they support the practice and support the business. The great thing about other roles is, of course, that they are more affordable than GP sessions. So Jonathan Cope, who I'm sure many of you will know, he's the Pulse GP of the Year. He's the senior partner at Beacon Medical Group in Plymouth. And they work on this principle that 11 GP sessions is equivalent to 19 sessions of another professional. And there can be a whole range of different professionals. Most practices are used to nurses working in practices, but also there are paramedics who, so in some places they'll run visiting services, in other places they can help with managing the on-the-day demand. Clinical pharmacists, and there's been lots of work on the whole pilot scheme by NHS England. Physiotherapists, and that's not so much physiotherapy being done in the practice, this is more physiotherapy assessment being carried out by often an extended scope physiotherapist who can deal with a lot of the presenting patient demand around back pain and other joint pain. And increasingly, physician associates, and there's a bit of resistance, I think, from many GPs to physician associates, particularly because they can't order X-rays and they can't prescribe. But the practices that have taken physician associates on, who've invested the time in them, have found them to be a really useful resource in practice because they can deal with a wider range of clinical conditions than the narrower scope of some of those other roles. Again, taking on other roles isn't always the right solution for every practice. It's particularly a good solution when GP recruitment is the key issue, when autonomy and keeping autonomy is really important to a practice, and what the practice wants to do is find a way of making its existing size work well. But from those places that have taken on other roles, what they would say is start with the individual where you can rather than the actual role. So if you know someone already, you know as a set of values that they will be a really good fit for the practice, then they're the place to start. Whereas if you do a cold recruitment, get someone in that you've never met before, it's higher risk for the practice. Any individual coming in a new role into a practice will require GP support, GP investment of time in them. And so what practices need to do is be really clear that to get the best out of those individuals, they're going to have to invest in terms of training, development, support up front. And there will be this period of double running. But all the practices that have done it have said that is worth it. So It isn't an immediate solution. It's not a solution that works immediately from day one, but done consistently, sticking to it as a strategy over time has worked really well for some practices. Now, a place that many practices now are turning to is operating at a greater scale. And with scale, we've got this, it's not just practices merging, we've got this whole new plethora of types of larger GP practice organisations. So on top of the GP practice, you've got obviously larger merged practices. Large practices have got to such a scale that you've got practice chains, which essentially are large practices with a single operating model. And when a practice joins, a new practice joins that practice chain, they basically have to take on the operating model of that practice. And that, for example, modality is a good example of a practice chain. There are also super practices. So our health partnership in Birmingham is a good example of a super partnership where there is more local autonomy for the individual sort of member practices, but they've all joined together and created a central management resource who can deliver efficiencies and benefits such as a single accounting structure, single CQC registration, some sort of internal quality control. More commonly now, especially with the development of the sustainability and transformation plans locally and the desire for general practice to work at scale, we're getting this sort of informal alliances of practices working across a geography and support being given to that joint working by commissioners. And that looks slightly different in different places historically, and still we have federations, and so these are organisations operating separately from the practices. And then we've got the new models of care, the multi-specialty community providers and the primary acute care services. So there are a whole set of different types of larger general practice organisations. The opportunities that come from operating in a larger practice, so essentially now we're talking a merged practice into covering a bigger population, is one, there'll be more GP partners. So the risk is spread amongst more people. So if your main problem is there's not enough GP partners, we can't recruit new GP partners, and other practices are struggling with the same issue, coming together can create that critical mass of partners that's needed for any practice. The bigger you are, the easier it is to introduce new roles. So you can still introduce new roles and merge. These aren't either or alternatives. And the bigger you are, the easier it is to do it because you've got a greater overall turnover, and so the sort of financial risk of investing in a new role is much less. Where practices start to operate, particularly if they're operating 20,000 plus as a population, and particularly over, say, 3 sites, then a number of places, and we've got examples, there are links in the slides there to St Austell Healthcare and Ocean Health in Plymouth, where they split one of the sites into what they call a hot site, so all the on-the-day demand is managed, and the other sites become sites for the routine and follow-up work. And changing the way that the practice operates like that can make just managing the workload much better. Larger practices can then create new partnerships and relationships with other organisations. They can accommodate part-time GPs better. They can accommodate GPs who want to create specialist interests in a certain area better, and they're also able to access funding that is only available at this sort of magic number of 30,000 often. So we talk about the extended access funding that's coming. I mean, the guidance is generally that needs to be covering a population of 30,000 or more. So if practices are already at that size, they can take the totality of that money and work out how they're going to do it for themselves. Whereas if they're having to work with other practices, there's going to be a sort of shared overhead that also needs to be funded out of that money. It isn't all plain sailing though. So it's not. I do think it's important for people to understand that merger isn't just benefits. There are also problems that come with merger. If you take two practices who both have significant problems and you put those two practices and you merge them together, those problems don't magically disappear. Those problems can still be there, and if they're together in one organization, sometimes those problems can be magnified. And so merging on its own isn't the solution. What's really important is that practices who are going to merge or thinking of merging consider what would we do differently that would mean the problems that we have can be tackled more effectively by us working together, and not losing sight of that as practices get into what can often be complex and drawn out merger processes. If practices work very differently, if they've got different values and different culture, coming together to create one new culture, it can often be a difficult process. So in a way, merging itself can create problems that didn't pre-exist in the separate organisations. Now, where a newly merged practice has strong leadership in place, then that can be overcome quite quickly. But where practices don't have clear and strong leadership, then those things can fester and they can go on for years and years. And sometimes you go into practices that have merged, and there'll be, the site maybe that merged last comes in and they say, oh, we do things differently, but we're not treated the same as the other sites in the practice. And so those, you can sometimes feel those things years later. Some staff don't like change, so sometimes what you find is when you merge, some staff will leave and you get some turnover of staff. That can be a good thing, but it can be disruptive. And the Nuffield Trust in their report Is Bigger Better also showed that the quality of care that patients receive from bigger practices can decrease as practices get bigger. And it's not a surprise with general practice being built on personal care, on continuity of care, on individual patient lists. And it's not necessarily true that the quality has to decrease, but practices that merge need to actively manage to ensure that that doesn't happen. Collaborative working, so if you're not going to go all the way into merger, if what you're going to do is say, oh, can we have a more informal set of joint working between practices, that can potentially help. I mean, it's changed over the years. So in the past, it used to be a way of practices working together to basically get work out of secondary care, to create almost like a separate income stream for the member practices. I don't think it's like that anymore. So more now, it's about practices working together to think about how they can collectively support their core business of their own general practice surgeries. So that's where the primary care home sort of model feels to me slightly different than traditional federations. The question always to ask is, how much is it going to cost us to actually set up the overhead of the federation, and will the benefit we get out of it be significantly higher than that to make the whole thing worthwhile? So some places, I mean, there are some great federations out there, and I'd include City and Hackney and Suffolk amongst them, but they are thinking, is federation the right model, or should we be moving into more the super practice model so we can be closer to the core business of our member practices? I mean, when I think about, should you go for full merger or should you go for a federation? In a merger, you have one management overhead, one set of accounts, you can make decisions, it's built around the core PMS contract, you've got control for the practice, so a load of benefits, but it's a lot of upfront work and mergers are hard to make happen. Whereas a federation network has different management overheads needed, this whole risk that the practices may end up being set against the network. So the network or the federation starts to do some work, that means is almost income lost because the practices were maybe previously doing it themselves. Things happen by committee, not through a single decision-making point. And you have a whole set of VAT and other issues from contracts and pension issues, contracts that aren't core NHS contracts. So you've got this sort of downside, but they're easier to set up. So they're easier to make happen quickly. And so I think often we end up with federations when what we really should be doing is the hard work up front and actually moving into mergers. And the fourth option is new models of care. And the way that I would think about new models of care is how do we get a relationship between the practice and other providers, so the community trust, or in the case of an MCP, or the acute trust in the case of a PACS. And so you can understand the benefit that comes from that. They have a whole workforce that they can then potentially use within the practice. They have a whole set of back office functions. They've got HR, payroll, IT, a whole set of things that they can apply to the practice, and those things that would be immediately available. The primary care home is slightly different, because that's really about the practices maintaining control as a group, and then building relationships, say, with the council and the social sector. And I think the opportunities there come from potentially taking on more accountability, more responsibility for the population as a whole, and so more ability to make the practice, that this larger now practice, work financially. Having looked at the MCP contract in detail, it seems unlikely to me that the MCP would really be a joint venture between an individual practice and a community trust. I think it might be between a joint venture between a group of practices and a community trust. But essentially, it feels, for an individual practice thinking, what are we going to do? Almost it's like an exit plan. It's like, we'll let the community trust be in charge. It can run the MCP. We'll essentially become salaried doctors working within it. The same is kind of true on the PAC side, just applied to a hospital rather than the community trust. Really interestingly, we're seeing a number of examples, and I've listed a few there, like Northumbria and Chesterfield, where instead of it being a PACS model, it's a straight APMS contract. So the hospital takes on the contract for providing GP services, and the GPs become salaried employees and part of the hospital. So I've talked through 4 routes that practices can take. So making the existing model work, introducing new roles, operating at scale, and considering the new models of care. What I would say is the critical factors to think about are: start with a clear understanding of the problem that's shared across all the partners. Make sure of the solutions that you're thinking about, they actually match and will solve the problems that you've got. Change is difficult and it requires leadership, and you need to make sure that the right GP or right team of people from within the practice are leading this change, and they are given the specific task of leading this change. You can't do it by committee. You can't move at the pace of the slowest. You've got to get the right person making this happen for the practice. Key is going to be building relationships. So all these solutions require relationships, whether that's between the partners within the practice, between different practices, or between the practice and different local organisations, hospital, community trust, district council, whoever. And finally, I would say make sure you set a timescale. If the practice is in a place where it's saying it's in crisis now, work out what the if we don't change by X date is, and what we will do then, as well as at the same time say, okay, what are all the potential future scenarios we can develop, and make one of those happen. Hope that's helpful. If you want to get in touch, then do. My email address is ben@ockham.healthcare. We do a weekly podcast about innovation in general practice. Again, look on our website and you can find an episode. We have a new episode every week on there, and hopefully I'll speak to you again soon.